Dr. McGorrian is a consultant in cardiology and acute medicine and is an associate professor in UCD. Dr. McGorrian is a graduate of the Royal College of Surgeons in Ireland and has been working in the acute medicine services in the Mater Hospital since 2012. Dr. McGorrian also specialises in screening and management of families affected by genetic cardiac conditions such as long QT syndrome, which is why we're here today, and also in sudden arrhythmic death syndrome. And she does this through her cardiology clinic in the Mater Hospital's Heart House. And today, Dr. McGorrian is going to cover long QT syndrome in relation to the adult population. Dr. McGorrian is a consultant in cardiology and acute medicine and is an associate professor in UCD. Dr. McGorrian is a graduate of the Royal College of Surgeons in Ireland and has been working in the acute medicine services in the Mater Hospital since 2012. Dr. McGorrian also specialises in screening and management of families affected by genetic cardiac conditions such as long QT syndrome, which is why we're here today, and also in sudden arrhythmic death syndrome. And she does this through her cardiology clinic in the Mater Hospital's Heart House. And today, Dr. McGorrian is going to cover long QT syndrome in relation to the adult population.
Talk on long QT syndrome in adults. So I kept it quite top line. Because I suppose, is that going to go forward for me? Let's see. What I felt is, of course, this is an audience of people who may be at different stages of their long QT journey, and there will be some people who have long QT themselves, and then other people will be family members or supporters. So I thought I'd talk in some quite broad brushstroke terms around what long QT syndrome is, and then a little bit on diagnosis, genetics, the management changes, and some of the change in treatments. I know we've got our key supporters around long QT services in Ireland with the Mater Foundation and the CRY, our colleagues in Tala, Belfast, and of course Terry in Our Lady's Children's Hospital in Crumlin. And there's a few friendly faces there. That's us all doing a big walk 2 years ago, I think it was, to raise money for research. So a few of the friendly faces anyway that you'll know. So what is long QT syndrome? This is I'm looking at the audience. I know it's a very knowledgeable audience, but essentially it's sometimes I describe it as a hidden heart condition. It's inheritable. It can be hidden. The person doesn't look any different. They may not have any other features except this predisposition, this risk factor to have a cardiac arrhythmia. And this arrhythmia can cause something like a blackout. And the medical term that we use for that sometimes is syncope. So people will talk, you'll see that in the medical literature. Or in its most severe form, a cardiac arrest. And I know we mentioned that terrible shadow of sudden cardiac death. And I know that there's always families involved in these talks that have had the tragedy of a sudden cardiac arrest. We used to think more about long QT syndrome being acquired, and certainly you can get QT prolongation relating to other heart conditions or medications, but fundamentally we think of long QT as a family condition. And the statistics can vary a little bit, but about one person in 2,000 to 2,500 people will have long QT syndrome and can be at risk of collapse, syncope, or sudden cardiac arrest. Of course, if long QT is in your family, that it's not 1 in 2,000. It's up to a 50-50 chance. It may be less than that, but the risk is more if somebody in your family has long QT syndrome. So what's going on, and what is this QT, and what on earth is she talking about? Again, I think this is a pretty knowledgeable audience, but just to run through it for anybody else out there. Of course, we think about our heart as a pumping vehicle. It pumps the blood around our body. We think about the little tubes that come out of it, and we think about the tubes that feed the heart and cause heart attacks and things like that. But quite often we don't think about the heart's signaling system. So the heart, I sometimes say it's a bit like a house. It has a signaling or electrical or wiring system in it. And what this signaling system does is it communicates across the little heart cells when to squeeze. Because if they don't have that good communication, if they don't have a message that they pass from one to another, how would they know when to give us a lovely big coordinated heart squeeze? So this diagram here, and in the purple, you can see the little lines of the heart's electrical system. And actually, oh yeah, there's my pointer now. And actually these points then, these parts of the system and structures relate to what the ECG is. I'll come to that now in a second. So essentially what happens, well, how is the signal passed from cell to cell? Up in the top left, you'll see a little picture of some heart cells, and they're all lined up and connected from side to side. And essentially what the little cells do is that they pass this electrical message using electrical salts, using potassium, magnesium, chloride, from one to another. And they pass the message on over milliseconds. And that's how the heart knows when to squeeze and to beat. However, in people who have long QT syndrome and other channelopathies as well, those little signaling mechanisms, those little pores that carry the salts in and out of the cell are set up differently. And different types of long QT have a different change in those little pores, or what they call channels. And they affect how the heart communicates its message and how it gets ready for the next message as well. So here's a picture of the ECG beside the heart, and what you can see on the right-hand side is the different parts of the ECG. And this was Willem Eindhoven. I had to Google it before I came on there because I keep forgetting his name, who identified the ECG. And essentially he gave these letters. He gave each of these bumps, which all represent a different part of the heart cycle, letters. So that's where the name QT came out of, because he called this little divot here Q, and he called this big yoke here T. And that's where the QT is. So that's what long QT is. It's actually a delay in the heart's electrical signaling and resetting process. But a person doesn't look any different. They mightn't be any worse or better at sports. They mightn't be, it's hidden, So these are some ECGs that show that QT prolongation, and these are just little snippets. But what you can see from these little strips here, I suppose the one on the far right, if you have a look, we've got our little Q wave that Eindhoven named, and then we have all the way out here the T. So this period here is too long. It's longer than what it should be in somebody who didn't have a genetic long QT syndrome. And this then predisposes that person to collapse, blackout, or in its most severe form, cardiac arrest. So what tools do your doctors, your nurses, what tools do we use to identify the long QT syndrome? And the baseline is the ECG, of course, that you just saw. And then we have different criteria to try and bring other pieces together, because the ECG is only one part, it's a snapshot, it's a very core part. But there's other risk factors that we pull together as well. And on the right-hand side, you'll see, and it's in tiny writing there, a little diagram relating to the different factors that we add in to build up a score. And this is an old score, actually. This was created by Peter Schwartz back in 1993, but it actually remains a bit of a go-to around diagnosing long QT. And so things we take into account is how long the QT interval is on the ECG, if the person has had any rhythm disturbance, if the QT itself looks a little unusual on the ECG, if it doesn't look like the regular one, say if we do an ECG on me in comparison to somebody else, then we look at symptoms. And so very significant is if a person has already had a collapse or a blackout, and then of course family history and gene findings. And in our Heart House clinic, and I know with our colleagues in CRI and other cardiology clinics, we do a few careful tests and look at them. We do ECGs, which are very simple, just a snapshot, but we also try and do Holter monitors, like a monitor you'd wear for 24 hours. And treadmill testing can also be helpful. Adrenaline infusion testing is interesting. The current guidelines from the European Society of Cardiology, and you might say, what on earth am I talking there? As doctors, we always look to our national and international societies to give kind of best guidance on how to look at important topics. So one in cardiology is the European Society of Cardiology, that are, hugely respected. And their most recent guidelines didn't recommend adrenaline testing as one of the core testing pieces. So we kind of keep that as an occasional option. And the long QT, I suppose, another thing that gives us a diagnosis is a mutation, a gene mutation. So we will come to genetics in a minute. But if a person has what we might call a definitely pathogenic or an unequivocal finding on their gene test of a long QT gene mutation, this does give them the diagnosis of the long QT syndrome also. And it means that they might be at risk of the kind of the complications of fainting and blackout. Um, and uh, we don't do community testing, of course, for long QT gene mutations, but we would look in families where we would think that there was a high risk or a particular issue, or if we knew that another family member had a pathogenic disease-causing gene mutation. And that brings us to genetics, and gene testing really over the last 15 years, thankfully, has become more available, but also its importance has become clearer and clearer with time, because the gene which is involved helps us name the type of long QT that a person will have. And then that allows us understand a little bit more closely what that person's medication should look like, what their lifestyle modifications should look like, what their personal risk might look like as well. And it's also really helpful then for screening the family. Once we know that a person or a family has long QT1, that doesn't change from then. So typically, I've been asked this in the past, will it become 2 and will it become 3? So once we know which gene is involved, we can put a label on that type of long QT. And as I say, it really helps us understand then how we can most protect that family. Um, and gene panel testing is, I always call it a gene hunt. So if, for instance, a person or a family come up and long QT is a new finding for them, the first thing we do is quite an in-depth gene hunt, and we look at all the long QT genes that are currently known. Our scientists will actually sequence, they'll look at the gene information available in all of those genes, and they'll look to see which gene variant, which of these little ones, the KCNQ1, H2, which one is singing out that it has a variation or a change, or the old word is mutation, but I always think it sounds like kind of X-Men or something like that. But a gene change in it that's caused this electrical predisposition. And why don't we find a gene in all families? Because there probably will be some people online. Because in 25 to 30% of people, when we think they have long QT, we can't find a gene, and that's dreadfully frustrating for that family. In some cases, it may be because it's not a familial condition, but in most cases, we still check family members to be very sure about it. It's interesting. Why can't we find it? I suppose one thing to know is that discoveries and even gene discoveries and other subtleties like copy numbers or whole genomics discoveries are still being made. There is increasing evidence that some other conditions can cause QT prolongation aside from channelopathy, long QT syndromes. So some small evidence to say that very high blood pressure with heart muscle thickening and other metabolic or neuromuscular conditions, we can see QT prolongation in them. And then some people may have polygenic patterns. And what that means is kind of polygenic means multiple gene patterns. So it's not just one gene variant. There might be a few, and some of them may be QT prolongers, and some of them actually might be QT shorteners. And we find that very hard to define. On the right, you can see just a little paper that myself and Joe, in conjunction with Sally Ann Lynch, were proud to print, which was the setting of QT prolongation in a person who had a different kind of complex metabolic condition. So we can find these other things as well. And again, this is another really busy slide, but this is for people, and I know that again, there'll be people there who are interested in long QT 1, 2, or 3. This kind of gives us an overview of the similarities and differences, little subtle differences that we can find between different types of long QT. And just for your information, a lot of these images I took from this really good paper um, by Arthur Wilde, and Arthur Wilde would be one of the kind of long QT gurus. So it's a really nice summary paper, and I'll give you all the name of that at the end as well, because a lot of this information is free to access for anybody. But essentially, I suppose even in terms of this little one here, we've got long QT 1, 2, and 3. I hope I'm not going horribly over time. And even when we come down here to therapy, we can see that therapy is a little bit different. So you can see how the genotype is so important. Slightly different triggers of collapse events as well across the different types. So genotype is really important. So if we have long QT, or if it's in our family or a personal or a family member, what do we need to do? What precautions are there? And why are we taking these precautions? And it can be a very hard. I mean, how many years are we kind of working in this, and I still find it hard sometimes to conceptualize. You know, risk is a hard thing to conceptualize, and what ifs and maybes, and they're very unsatisfactory. So you know, we're thinking, if I do this, we reduce the risk. If we do this, we bring up the risk. You know, and I think for patients as well, and particularly for young people, it's hard to conceptualize. Again, thanks to Arthur Wilde and his colleagues over in Holland. But this was a really great image that I thought really helps us understand what's going on with the QT interval. If you can see here in slide A on the left-hand side, there's that PQRS that we looked at earlier on. There's the QT interval marked out for us in brown. And I suppose we can almost think that the QT interval is made longer by our gene mutation, whether that's our long QT1, 2, 3, 5, 7, whatever gene mutation it is. That puts us then into a period of increased risk of collapse or blackout above and beyond the normal population. And a lot of the management, and I'll talk about it in a moment, relates to things like taking precautions around medicines, hypokalemia, and how do they affect us? They give us a temporary increase. So you can see that the idea, the image is of a sort of a weight pulling that QT out even further. I think it's a really helpful kind of imagery around why these pieces are helpful to us. I'm just trying to minimize that so I can see everything. Hang on, there we go. Help us image or imagine, I suppose, why QT prolonging drugs or why hypokalemia could give us that temporary risk. And then I know I mentioned earlier on that some people have protective or polygenic situations. And certainly we find in long QT, for instance, particularly long QT1, some people don't show it up so much as other people. And perhaps they have some gene variations or alleles that are a bit protective. So you can see in this last little one, the little hand is tugging back the weight. So it's supporting the QT not to be so prolonged. So a nice kind of concept around risk and why we're trying to modify some things. Particularly, the first thing we always talk about in the clinic is about avoiding QT drugs. I'm never done talking about the QT drugs. And you'll find a list of them. It's a really good tool, a searchable list on crediblemeds.org. But these are some of the ones that I specifically talk to people about because they're over-the-counter medications. So domperidone is a QT prolonger. And of course, that was aggressively marketed a couple of years ago, actually, with this image of the bloated frog, if anyone remembers that. Phenylephrine and pseudoephedrine, these are decongestants. They are known QT prolongers, and sometimes they sneak into composite medications like this one. Another one sometimes, I think, I won't give any proprietary names, but there are some of those sort of composite medications. Just have a look at them or ask your pharmacist, is there phenylephrine, is there pseudoephedrine in this? And then, of course, we've got groups of other medications that your GP or, you know, hospital carers might give you. And again, one thing I always say to families, everybody's sick of hearing me say this, is that although we might find out in the Mater Hospital or Tala Hospital or Mullingar Hospital that you have long QT syndrome, we do not have a unique health identifier. This information isn't necessarily available if you go into a different hospital or into a different GP, and people have to be advocates and they have to say, actually, I have long QT or it's in my family. Are you sure this medication's okay for me? And that goes for any healthcare contacts into your, dentist, anything at all. I talked about hypokalemia, magnesemia, and we talked about how they can pull out the QT as well. I always say this as well, our potassium, our diet and our kidneys really regulate our potassium and magnesium very well. And on the main part, we don't have to worry about this. But if we were on strong diuretics, these are sometimes tablets that people use if we're having a lot of fluid overload in our lungs, or if we have a gastroenteritis or a colitis that's causing a lot of diarrhea, vomiting, and we're not feeling well, we're getting dehydrated. That is a situation where if you also have long QT is a potential risk. And going to your local healthcare provider or ED for a potassium check can be helpful. This is a little bit about treatment, and I know I'll probably keep whizzing along until I hear Aileen shouting at me. But again, this is a really nice kind of flow chart again from Arthur Wilde. And you can see at the start here, you start with your long QT, and then we break into groups about how we're going to be treated. So you can see top right, everybody has to avoid QT prolonging drugs. Everybody has to have their potassium, magnesium okay, which everybody has, unless they've got one of those other situations going on. And I put this big red arrow in because essentially what you can see is that it doesn't matter what condition you come in with here, everybody qualifies for a beta blocker all the way across. So beta blockers these are our medications, and these are our cornerstone of treatment, actually for all the long QT subtypes. And then some people will go into different classes in terms of other pieces needed, such as cardiac defibrillators or left cardiac sympathetic denervation, different therapies. But beta blockers are a fundamental. And then that can be a challenge because, of course, people will have sometimes side effects and sometimes challenges tolerating their beta blockers. But right across the board, they're very protective and helpful in long QT. And I won't dwell on this, but essentially our information around beta blockers, what has grown out is that our non-selective beta blockers, so that relates to a particular way that they work, but nadolol and propranolol come out again and again as the superior beta blockers if a person can tolerate them. Not everybody can, but they are preferred if we can manage them. We do have other medications then that we sometimes use. So for instance, mexiletine is a medication that recently has been used in long QT. And oh, I didn't mean for that to happen. Hang on now. And has an ability to shorten the QT. There's experimental interest in a different medication, which is sort of relates to the KCNH2, the long QT gene called lumacaftor, but it's really only in experimental phase at the moment. We talked about the lifestyle. I didn't talk about sports restrictions, but I can if that comes up. And then our devices are surgical, and these are carefully selected for individuals. They may or may not be necessary depending on your personal or your family member's personal history. And we weigh up the pros and cons with the person as well, or if any of these are needed. The next couple of slides are kind of interesting because I think understanding how treatment goes in terms of these different options of treatment can be kind of illuminating, even as an individual thinking, well, what's my treatment and what should be considered for me? Again, this comes from a nice paper which anybody can access on the internet. And it comes from Mike Ackerman, who would be, again, a bit like Arthur Wilde, another long QT expert who would publish a lot in this field. And this comes from his own clinic, actually, where they describe, if you see on the left-hand side, this bar here, what treatment people were on when they came to his clinic, and then what treatment they were on by the end. And he's done this for long QT 1, 2, and 3. Myself, Dr. Prendeville, Dr. Galvin, we reviewed some of this recently, actually, in one of our smaller group conferences. But I thought they were really interesting to show because I suppose what Mike Ackerman is showing here is that for his long QT1 patients, when they first came to his clinic, this whole big chunk of them here in the grey I'm pointing out there weren't on any particular medication treatment. And you can see how his bias is to get people onto the non-selective monotherapy. So that's the beta blocker, so that's your propranolol or your nadolol. And there were some people who didn't, oh, I keep doing that, don't I? Who didn't go for any treatment, and they've labeled that intentional non-therapy, which is also an interesting topic. And then you can see up here, probably about 30%, 20 to 30% of people then needed more complex treatment. So they needed cardiac defibrillators or cardiac sympathectomies, but the majority are in the beta blocker group. This is the same then slide for long QT2. And again, what you can see is untreated changes quite significantly. Only a small group now that don't have any particular treatment. Then we've got the beta blockers. And then you can see how tailored the treatment for the long QT people, two people had to be. A mixture of medication, cervical sympathectomy, ICD, mexiletine, different treatments in there. And I think it's even worse when we get to long QT3. It's super complex here. Again, you can see just this range of therapies that had to be brought in. So I think you can see from that, I suppose, how complex therapy choice is for people with long QT syndrome, for the people in whom therapies are needed. And it's really individualized. I think there's a lot of individualized therapy. And this is just out of one clinic. So, I mean, it really goes to show. I did mention earlier on that some people don't have the QT prolongation, even though they have the gene. In particular, that's most common with long QT1, we find, and backed up by one of the earlier slides as well. And I suppose a point we always make is that even if you have got a normal range QTC, if you carry the gene, you still have some risk of collapse, blackout, cardiac arrest, and precautions are still warranted. And how do we estimate risk, and what tools do we use in the clinic? Things like the length of the QTC, symptoms, what type of genotype you have, how you're doing on your beta blockade. If you're having breakthrough events, do we need to consider something similar? And then family history. But risk estimation it's not amazing in long QT. We do our best. There is a long QT risk calculator. It's fairly simplistic, but it is in the guidelines now to use that as well. So it's also available on the internet, and the website there is available also. So just as I say, there is lots of information out there. I always direct people to the Irish Heart Foundation. Your own clinic as well will also be able to give information. Google Scholar is an amazing resource. I use it a lot, and you don't need to have any particular university login to access a lot of information. And as I say, a lot of my images today came from this particular paper, which has that little symbol there is an open lock actually. So it's unlocked and anybody can have a look at it and access anything on it as well. So it's a really great overview as well. It's quite technical, but it is good. And I know a lot of people like to do deep dives. So I went a bit over time, but it's an inherited condition, of course, our long QT syndrome. Our focus is on risk reduction, risk mitigation. We do have really great data now and good high-level recommendations from the ESC, from a lot of observational data from the long QT registry. So we can support a lot of our interventions, but a lot of management is personalized. And just finally, the gene carriers, even if you don't have the QT very long, there are some precautions that those people should take. So I'll hand